Good afternoon, colleagues. Welcome to this session. I'm Philippe Roux. I'm Acting Director in DG Santé, responsible for public health, cancer and health security. I'm Acting Director at the moment. As you certainly know, the European Commission has adopted a global health strategy last year, and one of the priority in the EC in global health is indeed to prevent and combat health threats, including pandemics, applying One Health approach, and building a robust and collaborative surveillance network to better detect and act on pathogens is one of the guiding principles enshrined in our global health strategies. Such network will work on digitalization and integration of surveillance systems across the human, animal, and environment spectrum, strengthening laboratories' capacities and genomic sequencing capabilities, as well as workforce training, as you well know. Also, advancement on One Health approaches on antimicrobial resistance, strengthening surveillance systems and public health microbiology capacity are important areas for our candidate countries. As you all know, the COVID-19 pandemic has painfully taught us that having a real-time data out of fingertips is key to making the right political decisions needed for health and social measures. So in that context, we are international here, so it's good for me just to mention from the European side, in the Commission, together with the European Centre of Disease Prevention and Control, you know it surely as ECDC, and the EU and EEA Member States, we are currently defining the concrete implementation of the European surveillance strategy. We'll discuss that further later. So a stronger international and interinstitutional cooperation on epidemic surveillance is in the scope of our work, and that's very important, and that's certainly today's session. So to make it a start and to give it a start, let me perhaps first give a word to my Director General for Health and Food Safety in the European Commission. She has a long track experience in the Commission, so she will give you some elements about this session, and I would be pleased if the video could be launched for our address. Thank you.
Dr. Kaseya, Dr. Kluge, Dr. Iguazu, Dr. Amann, Dr. Grove-Krause, participants, colleagues and friends, welcome to this session at the World Health Summit dedicated to international cooperation strategies for effective and fit-for-purpose surveillance systems. Let me first start by saying how sorry I am that I'm not with you in Berlin in person. I'm really very, very sorry. However, you are in very capable hands of today's hosts, the World Health Organization's Regional Director for Europe, Dr. Hans Kluge, my dearest friend, and the European Commission's Acting Director for Public Health, Philippe Roux, my dearest colleague. As you all know, the European Centre for Disease Control is in charge of collecting data for surveillance from EU member states, analyzing them and reporting on them. I start from this fact. So we are very fortunate today to have its director, Dr. Andrea Amann, amongst us. This year, the Centre published a report. I think you all read it, outlining the lessons learned from the COVID-19 pandemic. There were many reports, but in this report, one of the central lessons is that surveillance systems must be digitalized, in time, and the analysis, the interpretation, the presentation of the data tailored to the needs of policymakers and the public. It's a very important point that the data are tailored to the policymakers. During the pandemic, countries were able to free up considerable financial human resources for surveillance and response. But our big challenge now is to transform our surveillance systems into fully digitalized, effective, fit-for-purpose systems which must be sustainable and manageable with the resources available in the future. Another central lesson is that we could do better when it comes to international cooperation, coordination, and solidarity. Information sharing is vital for epidemic surveillance. It was certainly vital after the sudden appearance of the Omicron variant in December 2021, which I am sure we all remember too well. We were only able to react to Omicron because South Africa carried out such comprehensive testing and sequencing work and immediately shared the information internationally. I am therefore delighted that the director of the African Center for Disease Control, His Excellency Dr. Kaseya, is part of today's panel in the discussion. I am equally delighted that Director of the WHO of Epidemic Intelligence Hub, Dr. Chikwe Ikweazu, has joined our meeting. My dearest friend has his hub located in Berlin, and I think it's very important for the world cooperation on surveillance. I visited this hub this year, and I must say I am very optimistic about its vision for collaborative surveillance. The work we do is fundamental, I think. It is, of course, a set of issues that we need to deal with. Member states, regions, and other actors are around. With that in mind, I'm looking forward to what the Executive Vice President of the Epidemiological Infectious Disease Prevention in Denmark, Dr. Tira Grove Krause, has to tell us today. Denmark has done tremendous work in further developing its surveillance system. It's really exemplary. We learned about many of the SARS-CoV-2 subvariants from the extensive testing and sequencing conducted precisely in Denmark. So, colleagues, friends, what to say more? With such illustrious lineup here today, I am in no doubt that this session will give international collaboration for epidemic surveillance and intelligence another successful boost. Now to business. So, thank you very much for your help and your cooperation.
So I understand I can move, I was said. And I would like now to invite, because we have 5 additional speakers for now, and I would like to invite Dr. Rio Pereinet to come and join. Also, to mention that you replace Hans Kluge, but we are very happy to have you with us. And I would also ask to Dr. Gnasig Gnongo to join on the panel. And you replaces Dr. Jean Kaseya. And thanks for being with us. We have Dr. Andrea Hammond, please join, from the European Center for Disease Prevention and Control, but I'm sure most of you know her already. And we have also Dr. Chikwe Ikweazu. Sorry if I wrongly pronounce your name, but you know I'm French, and the French torture the names of people usually. So, but I have full respect, of course, for you. And I think I'm just missing Dr. Tira Grove to join, and I think we are complete in here. So, international cooperation is very necessary but very complex, and you will see that we had some last minute, so I may be wrong in giving the floor to the right person at the right moment after the last minute changes, but it should be fine at the end of the day. So we have now, we will have an introduction by each of the panelists, and we'll have after that a Q&A session in which we'll have the opportunity to exchange with you, and the colleagues of the panel will have the possibility to also respond to a set of questions we pre-prepared so that we take some juice out of their experience. Let me then now start, if that's okay, by giving the floor to Dr. Chikwe, who is leading the WHO Hub for Pandemic and Epidemic Intelligence. And you're basically based in Berlin. So that's great. So you are Assistant Director General at the World Health Organization for the Division of Health Emergency Intelligence and Surveillance System in the Emergencies Program. So an important and key role. And you will share with us on the topic of collaborative surveillance. So the floor is yours.
Thank you very much, and thanks for the invitation to this panel and sitting with my esteemed colleagues. I think to frame the conversation a little bit on the role and purpose of surveillance, coming out of this pandemic, within the WHO Emergencies Program, we agreed to kind of redefine our work in 5 kind of concentric circles we call the 5 Cs. And it's not that we've defined new activities, it's just really how do we deliver them. And the thinking really is underlying the risk assessment and the definition of the problems is a group of activities that we put under the collaborative surveillance circle. And in order to then implement response activities, a group of activities we put under the countermeasures circle. But ultimately, with these two, once you identify the problem and you identify the solutions, ultimately, there are just 2 things we want to do. Community protection, protecting our communities, and providing safe and scalable clinical care. And in the middle of all of those are the coordination activities. So these are the kind of 5 Cs that we call the Health Emergency Preparedness and Response Framework. Now, to the collaborative surveillance C, which is where I'll spend a few minutes speaking about. If any of us was asked right now, how do we improve surveillance? We'll think about systems, training, equipment, new stuff that we do, new processes that we will implement, and more people to recruit. People, processes, and equipment. But it's not enough, because we've been doing that for years. And yet, at the biggest public health crisis of our lifetimes, leaders struggled around the world to make decisions. The data systems to enable leaders make decisions rapidly were just not built flexibly enough, did not have the agility, could not rapidly connect data from different contextual sources. And so we all struggled. And this wasn't a north versus south divide or east versus west. We saw even the richest countries in the world struggle with how do we define with precision and enough granularity where this virus is circulating, who's affected the most, what the risk factors are. Should I close schools? Should I close airports? Should I reopen schools? What impact will it have? So our proposal to the world to start addressing this is not to necessarily recruit only more people or buy new stuff or define new processes, but really work at the intersections. And so the definitive word in this piece that we've published on defining collaborative surveillance is not surveillance, it's collaborative. Because it's at those intersections that I think we have kind of lost our way a bit. We've invested literally, and I'll start ending with that, millions of dollars and euros and pounds on building surveillance infrastructure and systems for specific diseases across the world, for HIV, for TB, for influenza, for polio, we literally have labs dedicated to only one disease in many countries around the world. So a completely inefficient use of resources in a context of few resources. So this concept really is about bringing together, making sure that we're collaborating across disease areas, across the human and animal sectors, across geographies, across the event life cycle from detection to response to recovery, to make sure that at those intersections that we find a unique opportunity to improve. So to stop measuring ourselves only by how many pieces of equipment that we have or how much we've invested in people and human resources or processes, but really look at the intersections. And my final point on this is this imagery of a rope is not coincidental. It tries to depict the strength that is derived when a rope is formed by connecting its various strands. So by connecting its strands and not investing in just horizontal areas, we hope to achieve added strength and resilience in the surveillance landscape. I know that sounds a bit hypothetical, but in reality, in taking this down to the country, subnational level, it's really forcing ourselves to think, if I'm going to provide a big piece of equipment, whether it's for genomics, whether it's a big new data center, how can I ensure that that can be used by people, colleagues dealing with all disease areas, all levels of threat, and not just for one area, one region, or just human and not animal, or animal and not human. So that's kind of the framing, and I hope that helps the rest of the conversation today.
Thanks a lot. Yes, indeed. I mean, I already took note of two of your words. Many of them were interesting, but work at the intersections was, for me, something which should be an important take-home message, especially with lack of resources you have mentioned and the importance in the work. Let me perhaps now to give the floor to Dr. Iho Pererinets. I understand that you were Vice Minister for Health in Ukraine before joining WHO, and that you will now share with us a bit about what are the challenges for WHO European region on international cooperation for effective and efficient surveillance systems, data sharing and response coordination. So as it was said for me, you can either stay sitting or move, feel comfortable to be where you want.
Thank you, Philippe. Thank you, Chair. And first of all, I'm delighted to be part of such a distinguished panel. And best regards from Dr. Hans Kluge, who unfortunately cannot join today. We all know that our region, unfortunately, experienced a lot of acute emergencies that we as the WHO Euro have to address and support our member states. And yes, my practical experience from my own government and now learning and also adopting the tools that Dr. Chikwa just presented tells me, and I can confirm again from the practical experience, that this is not about the resources per se. This is about the efficiency. This is about pulling together what we already have in order to collaborate effectively and efficiently to identify the risks, analyze the risks, and then to address them effectively again. So let me just briefly stop on a couple of the challenges that we have in the WHO Euro, and also solutions that we already proposed as the regional office, of course, learning and coordinating with our headquarters and based on the feedbacks from the country offices. So we and WHO Euro, we cover 53 member states. We very geographically diverse region. We cover the countries from Atlantic to Pacific Ocean. We have countries, EU member states, that EU EEA member states, plus candidate and Eastern neighborhood countries, 39 of them, right? We also have Balkans country, we have Central Asia, Eastern Europe. So these countries are not only socially, economically diverse, but also politically diverse. And the coordination between the member states or supporting the member states to develop a reliable and efficient surveillance system requires a lot of effort from our side, and we are committed to be context-specific when it comes to actually addressing specific needs of the countries. And of course, in a geopolitical context where EU plays a significant role, as I said, requires us to build these bridges between the EU and non-EU member states, which gives us opportunity not only to share the learnings between the member states, but also to distribute different knowledge between the member states through different platforms that we create. This is not rather the challenge, it's an opportunity for all of us, for the global community, to learn what we can do differently. But the challenges, just named a few. Of course, we all experienced COVID, and we learned a lot of lessons. Doing our interaction reviews, for example, we clearly saw that the surveillance system to monitor and detect the risks, infection disease risks, for example, definitely requires better coordination even within the countries. It requires coordination between the countries in order to address cross-border threats. And this is not only the system issue, it's also sometimes a political issue between the different players. Second challenge that affects the effectiveness of the surveillance system implementation is health inequalities. Health inequalities, they divert the resources. They require government to invest in according to their political agenda in most sensitive, politically sensitive issues, redistributing the resources for the surveillance. And on one hand, we would think to what extent the access to the healthcare services affects the surveillance. Is again about the resources redistribution on top of the conditions that prevent people from seeking health and being effectively serviced by the system. The third challenge, which comes from the second, of course, is the dominance of the non-communicable diseases in many places in Europe, in many places in the countries, that again requires additional surveillance capacities and knowledge and coordination between communicable and non-communicable systems in order to effectively generate data and make effective decisions at the end of the day. Because why we are doing the surveillance? To have data on time, to generate evidence-based policy making. And during the COVID response, for example, in our region, jointly with the ECDC colleagues, we effectively work around conceptualizing and implementing, for example, public health and social measures. And based on the available data in the countries, we developed from the scratch a so-called calibration tool. The calibration tool was basically an online option where, based on the epidemiological data, countries could have adjusted the social measures, and as we call it, also non-pharmaceutical measures. So having access, timely access to data makes reaction and response more effective, more targeted, saving lives and the resources. So how do we challenge and how do we address these challenges in the region? Based on the COVID response practices, our regional director and WHO Euro initiated a Pan-European Commission on Health and Sustainable Development, headed by Professor Monti. This commission confirmed and proposed a number of important actions that the WHO Euro now is taking together with the partners. First item that was proposed is better coordination of international response. This is where not only countries but the international agencies ourselves have to find a better way to coordinate in order to support the member states in their own capacities. Second learning was that the early warning systems have to be in place in order to identify the risks faster. And in many places, we support the countries to establish the electronic disease surveillance system. And this is where coordination between and practicalities between the systems, data, digital health, practical and clinical practices support the data collection for better decision-making and faster decision-making. As a result of the Monti Commission recommendation, we established a Pan-European Network for Disease Control. This is a flagship initiative now for the WHO Euro. The first meeting of its advisory board already happened in Istanbul a few weeks ago, and colleagues from ECDC and Santé are on board as observers and members. The idea is to bring together not only technical institutions, but also communities and NGOs and international organizations to bring countries closer together, not only on a technical level, but also on the planning level, on understanding the risk and sharing the information quicker. The second solution and option that we explore and effectively implement through the digital health and technologies. WHO has quite an important and well-developed program. Just recently we had the joint conference on digital health in Portugal. We all agreed that access to data, transparent data collection, analysis, timely analysis, using digital tools is vital for decision making. As Dr. Chikma mentioned, with the vertical disintegrated systems sometimes, we also have to acknowledge that we have, because of technology-driven and because of the market-driven aspects, we have a lot of different digital tools right now. It's also a matter of coordinating and integrating these tools, which seems like quite a task for all of us, especially in industrialized countries where the technologies are driven by the market and market is driven by the consumers, and then it creates a lot of opportunities, but also challenges. Capacity building, not a simple training approach, but the capacity building going down to the national health education systems, curricula, defining the core elements and innovations that already been mentioned today, talking about the surveillance not only from the perspective of the system infrastructure, labs, human resources, but from the perspective of collaboration, coordination between the not only health sector but other sectors using the One Health approach. Transparency in data collection and virus sharing, something that is now being discussed widely, talking about the global health security architecture. These deliberations are still happening through the IHR amendment process, through the INB intergovernmental negotiating body debates, and I believe yesterday we got our last version of the INB Bureau draft document that talks a little bit more in details what we propose in terms of the data and biological materials sharing. WHO already responded to this request at some point, and we have WHO BioHub system that supports the according to the Nagoya Protocol principles, sharing of the materials. Just to briefly on other important but topics that requires also our attention, and we learned through the COVID response, engagement with the community, community protection, community engagement, community advocacy at the community level, empowering the communities to be to integrate with the local health services to ensure that the data, surveillance, integration of the protocols are also supported by the members of community. This is our answer to many, not so supporting movements like the anti-vaxxers. That's where it comes from, their communities understanding what we actually do and why it's important to protect broader community and by providing data and sharing the information. So the collaboration between the partners is vital. As Dr. Chico mentioned about the HAPR framework, 5 Cs, 1 C of the collaborative surveillance. We in Euro developing our regional strategy on health emergency preparedness, response and resilience called Preparedness 2.0. Collaborative surveillance is one of it, of course, and we use HAPR, this concept that developed colleagues from the HQ as the conceptual framework to operationalize, develop the action plan and bring more partners together. And we're also grateful for our colleagues from Santé and ECDC for being part of the Preparedness 2.0 development. I believe we have all ingredients to make our collaboration even more successful and to bring all the partners together for better preparedness. Thank you.
No, thanks a lot, Ivo. I would love to have the entire afternoon to listen to you because that's very interesting, and you have also mentioned many important elements here from the reflection on considering communicable and non-communicable diseases, but also you mentioned digital technologies as key, and that we have had here proof of it, and I think others will share the view. You also mentioned something interesting to me, which is the importance of community engagement. And last but not least, and giving then all naturally the possibility to give the floor to Dr. Gnasi Nongo after, is you mentioned that we need to be able to support actions and specific needs of countries. And I think if I well see the notes I have here, Dr. Gnasi, you before joining the African CDC, you were team leader of the UNICEF Global Malaria Program, and you held a number of key positions for UNICEF in Africa. And now within the ECDC, the African CDC, sorry, you are having a great responsibility on the surveillance across the African continent. So many countries indeed to ensure that you can help with and support with specific needs. So the floor is yours.
Thank you so much. But allow me to correct that I'm not Dr. Ngashi. I'm Dr. Koku, so Dr. Ngashi cannot make it. So I'm here on behalf of Dr. Ngashi, and allow me to take you the greeting from Dr. Jean Kasser, our DG. So I'm Dr. Koku. I'm leading the Surveillance and Disease Intelligence Division in Africa CDC, based in Addis Ababa. Thank you for inviting Africa CDC to share information about how we are organizing ourselves in terms of collaboration with partners. So let us start from member states. You know, surveillance is about collecting data, but not just data. We really care about the quality of data. And also, the finality of surveillance is to use the evidence that we are generating to take action. So if we are generating evidence and that one is not used to take action, it doesn't make sense. So we try to be, as Africa CDC, this umbrella for the 55 member states. And just mentioned that Africa CDC have 55 member states. And Africa is divided by 5 regions. So we have Africa CDC, the HQ in Addis Ababa, but we do have our regional collaborating center, one in Gabon, one in Egypt, the one in the northern, Gabon is the central, for the West Africa is in Abuja, for Eastern is Nairobi, and for the southern it's in Lusaka. So through our regional collaborating center, we touch base our member states. So how do we organize this? So at country level, we really try to organize public health surveillance at multi-sectorial level, taking in consideration the One Health approach. We help member states to build a system that can allow data flowing from community level up to the central level. So we help member states to develop a technical work group. So if we take each thematic like event-based surveillance, mortality surveillance, antimicrobial resistance surveillance, genomic surveillance, for each thematic, each program, we develop a technical work group at country level to come up with their SOP, their guidance, and the way the surveillance should be doing, and the way data should be flowing and sharing. And at regional level, we also develop a regional technical work group to allow countries to share data. Data sharing is the challenge that we are having because the lack of trust and the diversity that we have. You know, Africa, the 55 member states, some are speaking French, some are speaking English, and others we have different culture. And data sharing is a challenge, but we are addressing this by developing a data sharing agreement that we are advocating for member states to sign. So we have that data platform. So regional level, we want data to be flowing from country level to the regional level. And we want our RCC to be centralizing data and implementing all those actions at the regional level. But at continental level, we want data to be centralized at the HQ, which is Addis Ababa. So we are working on the data, public health surveillance, and the data digitalization system, health digitalization, with a lot of challenge in terms of infrastructure, access to internet and other things. But we are working on that. And also the way, actually we have a lot of partners working on data digitalization who needs a lot of investment in terms of data sharing. We need to have the same definition. We need to have a standard in terms of how are we working to have a common definition on what we are going to share, and also how are we going to operate, so the interoperability and how we put all partners that are working on data digitalization together. We are also working on that. So at continental level, we also need a subject partner. So we have a joint action plan with European CDC. We are working with US CDC. But we work to avoid duplication. So WHO and Africa CDC, in terms of implementing, we are one. We are one. So we work together, and you can see the epidemic intelligence from open source, WHO, we are with WHO, and we try to build capacity together. We try to put our effort together. We try to avoid duplication at country level. So in terms of collaboration, we take this at international level with all our partners, European Union, ECDC, China CDC, US CDC, and with our regional collaborating center and with our member states.
Thank you very much. First of all, let me apologize. I will fire myself for having not being able to adjust to the change, and especially because you're sharing with us very important information, and I appreciate that very much, so I apologize again. You mentioned the importance of the multi-sectorial approach, and also the importance of technical support at regional level on each of the elements that are to be surveilled. And you used also the word coordination. I mean, this seems to be obvious, but it's always better repeating it because that's very important. You also mentioned something that we are thinking at world level. You mentioned that in your continent there was 55 countries, and indeed this is an impressive challenge in terms of coordination. So really a lot to think and a lot to share. We certainly have to learn from you as much as you may learn also from the old European continent. And perhaps to lead to the next speaker naturally, first I wanted to say that you will see that the two last persons are ladies, and it's not a gender issue. A wise man always know that women have the last word, so that is the reason why I have the pleasure now to introduce to you, for those who would not know her, Andrea Amund, who is Director of the European Center of Disease Prevention and Control. I mean, I would say you are part of the DNA of that institution. You are there from its start and in different positions, and you will share with us now about the lessons that you and we have learned from the past pandemic to effective and efficient surveillance system in Europe. And thank you for that, Andrea. The floor is yours.
Yeah, thank you very much, Philippe, for the introduction and also the explanation for the peculiar order. So, good afternoon to all of you here on the stage and in the room. I'm really delighted to have the opportunity to put a spotlight a bit on the strategies as we move forward to improve the surveillance systems in the EU, but also globally, to become more resilient and sustainable for future crises. I believe the pandemic has left us with ample opportunities for lessons to be learned. especially in the area of surveillance. It has been mentioned that this is one of the big lessons that we see to be improved for the next time. If we want to really use data for important decisions on public health measures, on travel, on vaccination strategies that impact our citizens' lives, I think we have to improve the timeliness, the completeness, and the comparability of the data. Because the lack of standardized data has meant that analysis of risk factors for severity and effectiveness of medical countermeasures were not possible or delayed. And we see only now the impact, for instance, of school closures on the mental health of young people. Missing integration of data sources across healthcare levels impeded the monitoring of the severity and impact. And frequent changes in testing and social distancing policies also haven't allowed us, because we couldn't account for them, to improve the comparability of surveillance data between countries and over time. So there have been a lot of difficulties, and even now member states are still struggling to implement integrated and representative surveillance systems for the respiratory viral infections that can really inform us now in every winter. What is now the way forward? You can see there are a number of new actors that have been introduced in the landscape, but there have been also for actors that were during the pandemic, like ECDC and EMA, new regulations and new tasks based on the lessons that we learned. So we have HERA now, we have a new health security framework, a new regulation on serious cross-border health threats, and we have discussions ongoing on a European health data space. And I come back to this. So, and all of this is encompassed in the frame of the health union. So we have seen that these transformation of surveillance systems in the countries will be actually a large piece of of work in the coming years. And these large transformations have to be coordinated at every level. And we will foster this in collaboration with the member states. And I want to highlight 3 points here. First, when we think about this transformation and the size that is necessary for this work, we cannot just think of implementing this across all infectious diseases. We should prioritize. And one of the recognitions that we have now is that the most impactful pandemics come from respiratory viruses. So we see that influenza, COVID, and RSV are impacting the seasonal situation in the healthcare settings and for the surveillance. So I think we should start here. So there, the Commission, DG Santé, has made available 100 million euro for member states to actually use in this transformation to accelerate this if they need it. So, in the coming 3 years, ECDC will assess each member state to see how we can, very individually for each member state, support the improvement of the surveillance in a systematic manner. The second part is that we should really invest in developing effective methods and tools for the use of electronic health information. And we are doing this right now with our eHealth project that aims at starting with countries that can already use data from electronic health records for surveillance, for a limited number of diseases. We will expand the number of diseases, and we will add the countries during the years as they become ready to do this. We also have now in this European Health Data Space pilot a project to use data via this European Health Data Space for the secondary use of data. So I will not have time to go into this concept of the European Health Data Space. I think it is a revolutionary concept that certainly will need a lot of discussion. It is primarily used or conceptualized for individual health data to be placed there, to be available when people cross for healthcare cross borders. But of course, this data can also be used for secondary activities. And we are mostly interested, of course, in the secondary use for public health. And that brings me to the third point. For a lesson that we tend to forget, it's of course right and not necessary to put individual health in the center of it. Requires a change in thinking, a culture shift in the healthcare sector and in the population concerning the use of health data for public health. And that is something that we have to work on in the coming years as well, to make people comfortable sharing their data for public health. We have, of course, we work, of course, not only with our member states, but also internationally. And we have a very intense collaboration with with the countries in the neighborhood, the Western Balkans and Turkey, to strengthen their capacity to implement the EU legislation on communicable diseases. And we work with the European Neighbourhood Policy partner countries on providing tailor-made support to improve their epidemic intelligence, their preparedness and response activities and capacities, their risk assessments, and the workforce capacity. And these activities are also supported by grants from the Commission. So when we look at the wider global reach, of course, our major collaboration partner here is WHO, mainly the European office, because here we have a strong mandate from our member states to make sure that they don't have to do dual reporting. But we also collaborate, of course, with WHO Hub for Pandemic and Epidemic Intelligence, with Dr. Chikwe and his team, as well as with the WHO European Center for Preparedness for Humanitarian and Health Emergencies. And we have been liaising with the regional offices in EMRO and in AFRO. Well, looking closer at the CDCs worldwide, we have signed memoranda of understanding with China, the US, Canada and Mexico, UK and South Korea, and are in the process of renewing our administrative agreement with Israel. Discussions are ongoing with Japan and Australia and the Gulf CDC for establishing formal bilateral relations, and we are in contact with the Brazilians in their efforts to establish a CDC. You have seen, I have left out one important part because we have a very special relationship with the colleagues in the Africa CDC, and I want to dedicate my last slide on this. But just to say that this network of CDCs has been instrumental during the pandemic and also now after this. Our last meeting was in May, where we discussed issues on avian influenza. And now, as said, our partnership project with the Africa CDC, that is also supported by a grant from the Commission. I cannot go in all the details what we are doing with the colleagues there, but here is only the surveillance activities. And I have to say what we are doing is based on what they tell us they would need. And so we see how we can support what helps them to establish their core function of surveillance. So we have just finalized a study on an event-based surveillance mobile application, which we don't even have for Europe. So I think that is really good because that will help us to have something maybe in Europe as well. Just to conclude here, I think surveillance is for me the basis for public health evidence-based and science-based decisions. But it needs to be for future purposes, it needs to be automated, integrated and standardized. And this standardization has to be global, but also flexible enough that you can do local and regional adaptations. Thank you.
Thank you very much, Andrea. I mean, well, your conclusion could be the conclusions of this discussion of today. But you also mentioned a number of other things. First, let me thank you for having put in context, I mean, the European Health Union and components, and I think that's important that the ECDC is working in a bigger environment and that you contribute to the functioning of a complex but very useful set of tools that we have put in place, starting before but boost during the pandemic and after the pandemic. You mentioned one thing which is an element of importance for the Commission, which is anecdotal perhaps in the context of today, but you mentioned the mental health dimension. And I think that is something which has been neglected and luckily not anymore, and I think it's central to a number of policies, including within the Commission. So that's very important. You have mentioned concrete examples of cooperation at international level, and the work with Africa is worth being known. You also mentioned, and I think that's a link with the next speaker, because you mentioned that it's very important to make people comfortable to share their data for public health good. And I think I see nobody better placed at the moment than Dr. Gira Grove-Krause, as you are active at a national level in your country, in Denmark. And you're playing a leading role not only at national but also at European level by your involvement in a number of projects. So please, the floor is yours.
Yeah, so I'm happy to present the perspective from the national level, the member state level, on the importance of international collaboration in infectious disease surveillance. So I'm from Statens Serum Institute in Copenhagen of Denmark, and we work with surveillance of infectious diseases, outbreak detection. We also have national reference laboratories, and we do the risk assessments for the National Health Authority or the government. So I'll start out with a very concrete example from the risk assessment we did during the Omicron wave in January 2022 that actually formed the basis for the decision of the government to lift all restrictions in Denmark by the 1st of February, which I think we were the first country in the world almost to do. So it was really data for action. And I want to explain what kind of data we needed in order to make this risk assessment. First of all, we needed access to the international surveillance data, and that's both the indicator and event-based surveillance data. and also the laboratory and sequencing data from those countries. And I think, as Sandra also said, that we were very lucky that the Omicron variant was first detected in South Africa, because they could show us the data in a very transparent way on number of cases, hospitalized numbers in intensive care units, and also numbers of deaths. And we could see that it seemed as if the impact of the Omicron variant was not as severe as for the previous variants. But we also needed access to international research data, because we also needed to do epidemiological studies on the severity of the Omicron variant compared to other variants, the transmissibility, and also its immunoevasive properties. And the same is the case for the laboratory research. We also needed data on immune-evasive properties from the laboratories, or even animal studies, also looking into the pathogenicity of the virus. And this was a bit challenging, because, of course, there were a lot of different academic groups doing this work, but and most of it was also published either in reports or in open source on open source platforms. But still, it was difficult to follow what came out here. We also were very dependent on mathematical modeling. Before the pandemic, we were not so strong at our institute in doing this, so we had established a network with experts across the country that could help us making these models, so that we could actually project the case numbers and the number of hospitalized cases given the Omicron variant, and also the effects of lifting the restrictions, and particularly given the fast rollout we have had of the third vaccine booster that also needed to be taken into account. We were very dependent also on all the information that we got from the international institutions, the ECDC's risk assessments, but also the risk assessments from the Technical Advisory Group on Viral Evolution from WHO, but also the different networks, disease networks that we participated in. In particular, there was a network underneath WHO where ECDC also participated, where we had weekly teleconferences on variants and mutation updates from all the European countries, where we, in a confident way, could share information on what happened in our countries, what studies was underway, and when could we expect the results. I think these were very useful for us, also for our risk assessment. But there's also some things that maybe we can do better next time. So when it comes to the international surveillance data, it has been mentioned several times, but it's really important to build up this digital data infrastructure. And that's something we have been working on for decades in Denmark, to build up a microbiology database comprising all laboratory results, and also a vaccination register. And then we can combine these with other the data from these data sources with other healthcare or information from other healthcare registers. And this is a very flexible system that can also be used for other pathogens. So that's really important, that this is a focus on the digital data infrastructure, and also the interoperability if you want to be able to share data. We also continuously need to validate and also integrate new surveillance systems or data sources. So right now we have wastewater monitoring that we have been implemented in several countries, and we have to find out whether this is something we also can use for other pathogens. So that's just an example of a new system that we need to find out. Common study protocols that can be used when you have a new threat that you can follow for the epidemiological data, but we also need to have some laboratory networks, and that's also sometimes a challenge because we don't necessarily have the capacity at the public health institutes, but we need to work together with academia. And right now we are also participating in a laboratory network established by HERA that we are looking forward to participating in. With respect to mathematical modeling, I think that's also a part of the extended mandate of ECDC to work more in the field of mathematical modeling and projection models. That's also very important that we work together on this, because many of the parameters that we put into the models are the same for some countries, even though you need to have national models. We also have to, it's very useful if you have different modeling approaches and see and compare the results you get from them. And then I think there's also, we have to find out what is the role of artificial intelligence in surveillance, and I know that's also something that ECDC is working on. When it comes to the international networks, we need to work in a One Health approach, and I think I would really like to congratulate at the global level the One Health collaboration within the quadripartite, and also at the European level, this One Health cross-agency task force. I think it's still a challenge at the local level to succeed in this One Health approach. We have certainly been practicing in Denmark with AMR, and also during the mink outbreak we had. And I think we learned a lot from the organizational level, but we also need our ministries to work very closely together, because we need the political commitment if we really are are going to succeed with a One Health approach in disease surveillance and risk assessment, and I think we're not really there now. For the international networks we participate in, they're really important for capacity building and very useful for that. But what I think we have also learned is that where we could really improve is coordinating of the coordination with our responses, because we have responded very heterogeneously across all countries, and maybe a lot of this was due to political reasons, and maybe we cannot really succeed in this, but maybe we can improve the coordination of our responses. So that were my final words. Thank you.
Thanks a lot. I think you give an interesting perspective from how in the country international data can be also useful, and how you have used it in Denmark. And I think that's among the other messages you gave, one which I find very interesting and important. I know that you have a registry system in Denmark which is very highly performant already, so you have excellent basis for work, but that's just an element that contributes to the successful approach at national level, and it's important to note that there is indeed a need for also the international dimension, even when well structured. So thank you for that. I think we reached nearly in time, yes, if my watch is correct. Time for the Q&A session. I think we have heard about the different angles of surveillance systems, and I think that was quite important to hear from WHO, but also of Africa, CDC, ECDC, the WHO Hub for Epidemic Intelligence, and as I just said, from a national experience. So I think that was very useful and interesting. And perhaps, I don't know if there is someone who has a question in the room to one of our panelists?
Yes, there are two here.
Yes, I see at least one hand over there, and I suppose there are people with microphones, yes, and another here. So we can take two questions, at least. Well, I would say that we have up to 3:30 to finish, so please.
Hi everyone, my name is Nessa Marcus, Robert Koch Institute, and thank you so much for the very interesting talks, and I really enjoyed this session because it's a bit more hands-on from my perspective, since I'm more on a technical level working on surveillance. So this question is to the colleague from ECDC from Denmark, and also to Dr. Kuku. So, all to share the data, and this is at the end what limits our systems and limits our efforts. So how do you tackle that challenge, or how do you maybe even plan to tackle that challenge? How do you influence the different stakeholders that you need to have on board to make this happen? So it's not only a technical issue, but it's also a legal and a legal issue. Thank you.
So who wants to start?
Yeah, I can start because that is an issue that is very frequently brought forward when we are discussing with our networks the digitalization of surveillance, that, oh, the GDPR, the GDPR, the GDPR. And we have discussed this with the European Data Protection Supervisor, because, of course, ultimately they should tell us what is possible. They tell us that the interpretation of the GDPR is indeed the national remit. However, I mean, we are still working on them to give a bit more guidance, even if they don't, you know, provide the final interpretation. But they could give more guidance, and there is a board where all the national data protection supervisors are there, and we have to see how we can use that one. But the issue is also that we have to, and that is where the ECDC data protection officer has offered to talk to the national institutes to really tease out what is it that they find problematic at national level, because the concrete examples could then also help elucidate whether this is an interpretation that could be counter-argued.
Thank you, Andra. Another colleague who wants to complement?
Yeah, I can just say that I think it has to do also with the interpretation of the legislation, and I know we are quite happy that we now also have our Danish protection officer participating in this network underneath ECDC, so that they can raise the issues that they have and share experience with other countries.
Thank you. In any case, yes, data protection is to help and not to create barriers to health. So that is the challenge we are still in front of us, but solutions are slowly coming. So I'm very optimistic about it. And so I saw that a gentleman there first and another there again. So perhaps first here, if that's possible.
Yes, hello. Thank you very much for the insightful presentation. Nick Baumgart from Copenhagen Center for Disaster Research. My question would be, how do you see the role of civil societies in terms of surveillance systems, for example, in early warning systems, and also in regards to the risks of setting up parallel systems and how to navigate? Thank you.
Thank you for that question. I mean, the role of civil society, perhaps, Tira, would you want to have a go on that?
Yeah. We've had a several surveillance system based on citizens reporting to our national system. So we have one for influenza-like illness, where citizens report on a bi- or weekly basis. And we're also now implementing a new surveillance system where that we implement at workplaces, where the staff members are voluntarily asked to participate, and then they can report their symptoms once a week, but they can also swab themselves if they have symptoms, so that they can support the surveillance of all respiratory pathogens. And it's not only a surveillance system, it's actually also, we think of it as a test preparedness system, because if we have a system in place for self-testing, this could also be used in case we suddenly need to test more, as we did during COVID-19, where we didn't have the test capacity in place. So it's also like a preparedness testing system. So I think citizens' participation in the surveillance system, I think that's going to be important also in the future.
Thank you. One last question from the room, and then I'll take my advantage of being chair for a couple of questions too.
Okay. Perfect. Back here. Back here.
You were there. Sorry.
Yeah, so my name's Eric. I'm a physician coming from the Mayo Clinic. And within the U.S. healthcare system, things are very different, of course. My personal passion, artificial intelligence, machine learning, data safety, all that sort of stuff. But the things that I think of and worry about are, once these data become available, how do we protect the public, essentially, from governments, intermediaries, pharmaceutical companies, whatever, sort of weaponizing this information, whether it's genomic information, whether it's public health information, either to triage who's going to have access to things, because a big through message from this whole conference has been increasing access to the resources that are available. And I always worry about, as more data become available, how do we protect people from being discriminated based on things that they can't control?
Thank you. I think you have seen at least, but from the European perspective, I mean, Andrea already mentioned a number of activities that are being implemented. I mean, we indeed want to avoid a misuse of data. And that is something that is in the art of all the processes that we are putting in place. So my answer to you, before letting the other panelists, if they have complement element here, is that whatever we are doing, we take that element in consideration. And it's not for nothing that in the Commission we did put in place this data protection directive, and that was one of the reasons was indeed to avoid misuse of the data. But at the same time, as all colleagues have said around the panel, I mean, we need to have the possibility to use secondary data for purposes of research. We need to have the data for ensuring that we are able to make progress. I mean, I give an example which I know well because I'm also head of the unit that is responsible for cancer. I mean, we work with colleagues in DG Connect in order to ensure that we have we developed imaging for early screening, so at European level. So we're using information that may be considered as individual data to ensure that we have faster screening and discover cancer at an earlier stage, and so have a better chance to cure people. Not to use these technologies because of the risk of weaponization might be a mistake. So the best is to try to find the best routes to avoid that, and there are a number of technicians that are working hard to ensure that we protect the data and that we receive from individual patients. But I don't know, someone more equipped than me could contribute or would want to contribute?
I can just share a few thoughts. I think you're right, there is a risk of data being misused for one thing or the other. And we have to, through our various legislative approaches at the different levels, protect ourselves to some extent. But we also have to think always on what we're doing with the data that we are receiving and what we are not doing. So there are lots of opportunities that we've had. You can think about the recent Mpox global incident. Do we have diagnostics around the world today? No. Do we have a vaccine in development accessible to most countries around the world? No. Do we have antivirals? Have we learned better lessons in terms of utilizing the information we have to make global decisions, thinking that the emergence of Mpox internationally actually happened 3 years before this current outbreak happened? No. So there's a lot that we can do if we get better at thinking about the existing data systems. And it's not always more data needed in a lot of the areas of work. If we think about genomics, at the moment, everyone is pushing for more genomes to be analyzed. If we think about the opportunities of wastewater, exciting opportunity for wastewater surveillance, but apart from polio, I don't know any other disease where the baseline has been defined in terms of what can be interpreted from a signal to alert to a verifiable incident that would then ultimately lead to a response. So I think there's a lot of work that we need to do. I'm as excited about the new opportunities for analytics with AI and everything around, but I do keep insisting if we don't build from the bottom-up systems and ensure that we're thinking in an equitable way from the trajectory from the detection to decision-making, that we will devote too many resources to the intellectual resources, to the rare possibility of something harmful happening that may never happen, and not focus sufficiently on building the basics that we need to protect the world.
Thank you. So, yes, please,
thank you.
And then the last for the, yes, I've not forgotten you.
Yeah, thank you. I think the most important part is to be really transparent about what the data are used for. And that is, of course, when you build these databases, you build the data protection by design in there. Who can access, how can access, and what is what are the data, can the data be going to be used for? And to offer, and that's sort of a strong prerequisite from the data protection side, that the individual that has their data in such a database can at any time withdraw them.
Yes, so please, Tina.
Yeah, just to elaborate on this, I think I've been working a lot on establishment of the Danish vaccination register, just as an example. But when we launch this, first of all, the citizens, they have access to their own data. And as a parent, you can also look up the information on your children. So it's also an advantage for the citizen themselves. And then the main objective was also to improve the surveillance of vaccine effectiveness and safety. And I mean, that's really important to the citizen to have to be able to trust in the vaccination program that they are provided. So I think it really depends on how you frame the use of the data. And I agree with Andrea, it's very important that you know exactly what is the objective of collecting the data.
Thank you. Dr. Toko?
Yeah, just to add that this question is very important in terms of legal issue. So that's why we as Africa CDC, we develop a continental framework for everything. So we know what data we are collecting, who have access to that, how the data will be using. So all those bases are there. We agree on that and the way we move forward. I also want to touch base on the question on the involvement of civil society. This is very, very important. If you take like a mortality surveillance, for example, in Africa, at community level, where you don't have a physician to certify mortality, you go for, you need to work with religious leaders. You need to work with other, so you have access some of data. So verbal autopsy, for example, if you take Muslim religious, before you have access to all of those data, you need to work with religious leaders. So we make sure within our technical work group, we have those religious leaders. This is also valid for vaccination. You know, when we want to set up surveillance for vaccination, when you have those vaccine hesitancy, and we really need to work with community leaders, private sector, and all of those civil society to help us to reach the main population.
Thank you very much. I think that's very important, and indeed this dimension of the civil society and is really an essential element. It leads also to the other point that we mentioned earlier on ensuring that patients are aware and ready to share in confidence their data. And also before that, indeed, the involvement in civil society to understand and to help passing the message across is key. The last word in the room or question on this side for the gentleman, please.
Thank you so much for this informative discussion. COVID-19 came to taught us lots of hard lessons. And one of those hard lessons was related to data sharing and transparency. And let me mention here what happened with South Africa, when they were transparent, when they shared the information on a timely manner related to Omicron. So not only punishment for the country as South Africa, but punishment for the whole region of Southern African countries. So while we are now in the heat of discussion related to the pandemic accord, reviewing IHR, my question to Dr. Chikwe, how will you address as WHO this concern, this growing concern from the country? If you become transparent, if you share your information in a timely manner, you will be punished. Thank you.
I can help if you know.
Thank you. Firstly, to say the punishment did not come from WHO. In fact, if there was any organization, you would have heard many interventions by Dr. Tedros himself calling for both transparent sharing but also equitable and fair responses around the world. So what we can do, I think collectively, not just as a WHO perspective, is learn the right lessons from what happened in South Africa and Botswana, and who were the countries that identified Omicron initially, and continue to expand the capacity for surveillance ourselves, and every country to develop that capacity to continue to share, but also to work hard to build the frameworks. The discussions happening right now around the treaty are very important, and every country has to continue to focus on getting to that point. So by May next year, we'll have a treaty that we can all agree to. But there are many things a treaty can solve for, but there are many things it cannot solve for. It cannot solve for countries working together collaboratively every single day. And that happens. It's just that, when it happens successfully, it's not on the pages of newspapers. Every institution around the world has a group of people doing detection, verification, response work. They share this information. Very often a response happens successfully, and of course it doesn't make the headline. So I think the lessons from the political fallout of the pandemic is very important. It's up to our political leaders to learn those lessons, and we collectively as citizens have to keep pushing on them to learn the right lessons and see how our collective vulnerability can be addressed by collective action. But all of us on this panel work in institutions responsible for the doing every day at different levels, making sure we're collaborating both across our geographies, across our continents, and globally as well to get the work done. So if you'll accept that as a response without responding on the political level, but technically we'll keep pushing, and hopefully by May next year we'll have a new treaty or accord or whatever our member states decide to call it.
Thank you very much, Dr. Chikwe. I think you will have frustrations, but I will also be frustrated because I had a series of questions and it's too late for me to ask the questions. But I think it was a proof of the richness of the panelists and their contribution. You had many questions to them, so thank you to you all for your high-level contribution first. I think that's very important to me, to congratulate you. Thanks a lot. Really. And I repeat, it's the first time I can't ask my own questions in a panel. So normally nobody in the audience is willing to speak. Here we had, I think, a really high level of exchange, and I'm very happy of that because it is the way that it should always be. So thank you also to the audience. So thanks to you for having been for 1.5 hours with us. I think just one or two elements on my side. I can't wrap up everything what was said. I think all along I try to do my take-home messages, at least those that I will bring with me home and in my institution. Of course, there is a lot of work still in front of us. That's clear. I mean, the last interventions proves it, and definitely we need to continue to work and to transform the seeds that we have planted just before or during the COVID to transform a number of ad hoc surveillance systems into effective and fit-for-purpose surveillance systems. So still a lot of work, but as you can see, it's promising because at all levels I see that all actors are at least voicing in the same direction. So that's for me a good sign. And also I wanted to stress again that at least for the European level that I was modestly representing today also, is that in the frame of the Commission's global health strategy, we are really keen to work with European international partners and international partners to strengthen collaborative surveillance. So we have to transform words into a reality. It takes a bit of time, but we have already made a lot of progress. So thanks to you all, and I think I respected the time that I was given, so thanks very much.
Thank you.